So what characterises these conditions often is a young person does not respond to traditional treatments and often has quite adverse effects to traditional treatments. And often you see one thing tried after another and after another, and nothing really works. And that is one of the indicators to, or should be one of the indicators to say, well, maybe something else is going on. What are the alternative treatments if a young person has some of the other markers of these immune inflammatory conditions? They may have abnormalities in their serum. If you check for their immune inflammatory markers or antibodies, they may have markers in their CSF. When you do a lumbar puncture and you look at the fluid that bathes the brain, you may see these inflammatory markers. They may have changes on brain imaging or on EEG when you look at the electrical activity in the brain. They may have a family history. So if you take all of those things, and then it seems that the young person is not responding to traditional treatments, doesn't have a typical disorder, has some of these other markers of inflammation or autoimmunity or a family history, then what are the immune treatments that might be helpful? And that is done in consultation with neurology, with immunology, with the young person and their family. So they're given all the information about what might be happening or what is happening in their brain, what are the current treatments that are available, what are the pros and cons of those treatments, how those treatments might be sequenced. I'll talk a little bit about the treatment of these conditions and how we arrive at a decision, a consensus, that a young person may benefit from immunotherapy. These decisions are not taken lightly. A lot of the treatments that are involved do have side effects and can have longer-term consequences. So it really needs to be a collaborative decision, and a decision that is based on evidence. We don't always find a specific marker. We can't always find the anti-NMDA receptor antibody or another specific brain antibody. And that is because immune inflammatory conditions of the brain are quite diverse. They don't necessarily involve an antibody. They can involve other parts of your immune system. The antibodies that we can actually detect are only a very small proportion, a fraction of the ones that are probably, if you think about all the proteins in the brain, we can only detect a small portion of them. So we can't necessarily go on those markers, those brain markers themselves. We need to think about other things. What is the syndrome the young person is presenting with? Does it have the characteristics of an autoimmune encephalitis or a neuroinflammatory condition? And there are some very typical patterns that you see. Has the young person responded to traditional treatments, psychiatric treatments, or have those treatments, not only have they not responded to them, but have they made them worse? Do they have a family history of autoimmunity, or do they themselves have a history of other immune inflammatory or autoimmune conditions? What are their results of brain imaging or the results of EEG, where you look at the electrophysiological activity of the brain? So you put all of those things together, and if it looks like there is enough evidence to suggest that this is an immune or an inflammatory problem, then we try and bring together all the experts, the neurologist, the immunologist, the psychiatrist, the young person and their family, all of the experts, to come to a consensus about what's likely happening in the brain, what's the likely pathology based on that evidence, and therefore what treatments are likely to be effective. And the treatment is then personalised. What types of treatment you use, how they're sequenced, how that is followed up, how that is monitored, is all discussed at that meeting, and the meeting with the person and the young person and their family, and then decision made about how to go forwards. And the treatments vary from things like high-dose or pulsed corticosteroid treatments like you use in MS, for instance, or other disorders. It could be immunoglobulins, it can be immunosuppressant treatment. Sometimes it's as simple as using an antibiotic that has an immune regulatory component. Or it can be things that are more sophisticated, like plasma exchange, where you literally take the antibody out of the serum. But all of these things have a particular role, a particular sequence, and The most important thing is to be able to track the outcomes of young people, to see how they respond to treatment, to make sure the treatment is benefiting them and not causing them harm, and to make sure that we do the other things then, support with getting back to school, support with cognitive function, improving concentration, attention, helping young people develop the social skills and the skills with relationships that they've often missed out on by being unwell for a period of time, and supporting families who have been through this journey and often are pretty traumatized by the process. So there are many things that we also need to do to make sure that young people recover and get back on track again. So we've now treated over 40 young people with these types of unusual, atypical syndromes, in combination with neurology, immunology, with the young people and their families themselves having developed some skills in recognizing the common patterns that young people present with, and being able to work collaboratively to look at what treatments might help get the symptoms under control, but also help young people recover, get back to school, get back to university, get back to being able to participate in social and family relationships. And I have to say, we've yet to publish the outcomes of that. We continue to work on it, but the outcomes in the majority of cases have been very positive. So we see young people who have really, in the psychiatric system, being put into the too hard basket, really thrive and be able to go back to school, be able to go back to university, go back to being able to participate, but more importantly, be advocates. So a lot of these young people have been traumatized by their process through the medical system, and they are very good at standing up and saying, this is what happened to me. I don't want that to happen to anybody else. This is what your outcome can be if you get the right treatment, and encouraging young people and their families to really speak up and to have a voice, to be empowered in our medical system, which is very good at disempowering people. This area of research and clinical treatment has been a great example to me of how much we don't know, and how much as clinicians we need to deal with the fact that we don't know. We need to be able to deal with uncertainty. And often in medicine, we hide that from people. We don't want people to know that we don't know. But actually, if we share that with people, with young people and their families, and say, we don't know, but this is a problem that we can work together to solve. We can work together to solve it in clinical areas. We can work together to solve it in science. If we are more open about what we don't know, we can be empowered to actually solve problems together.